We worked very hard this year. We prepared with the help of Professor Seruyus and the Office of Eurointervention very nice supplement. In that supplement, we actually published consensus documents from the first 10 years of EBC existence. And we have also plans to continue working, sharing experience, discussing what is unclear or what we would like to refine. And we have also ambitious plans for the next year. And I'm happy to introduce 3 new consensus documents. One is an update on dedicated QCA software for bifurcation lesions, and the chairman of the committee is Professor Patrick Seruyus and his team. The other one, we just had the first meeting this morning, preparing a consensus document on bench testing, because we really believe we need to standardize procedure of bench testing for bifurcation lesions, and chairman of the committee is John Ormiston. And the third one, I hope will be ready very soon, and it's one for OCT imaging in bifurcation lesions. It was already introduced last year, and chairman of the committee is Niels Holm, and I hope we will have it very soon ready. So not to take much of your time, I hope you will enjoy discussions and exchange of experience and your data. And it's my pleasure to introduce the first session with 2 chairmen, Thierry Lefebvre and Jens Lassen, one on Boston Scientific Stents. Please.
Thank you very much, Goran, for opening the meeting, and let's get started. We need to, well, get up in speed. We are very interested in having a discussion on how we use the devices when we are going to do bifurcation. What is the capability of a good workhorse when we're doing PCI? What do we need when we do bifurcations? There is some characteristics with the devices, and some of them are the crimp profile, how is the diameter when we need to cross lesions and need to cross stent struts. What are the stiffness if the vessel is tortuous and you need to, well, have a bend pretty close to 90 degrees through a stent? What is the trackability, the crossability, and the pushability? And of course, when we do all these works with the stents, how is the polymer reacting, and is the coating capable of being intact after all the manipulation? And of course, also the scaffold properties. So if we have a little overview over the current stents, you know there are differences in shapes, in where the polymer is placed, and in the shoulders of the stents when you push them through. But most of all, I think we need to appreciate the Murray law with the correction of Finney and the final calculation of Hugo-Casap. What this law actually says is that the main vessel is most often tapered, which means that you have to modify a tube, which is exactly the same diameter in the entire length, to a conical shape, which is a kind of a test of what the stent can do. Again, when we're doing the bifurcation stenting, we do a lot of steps. We rewire, we use balloons, we cross with balloons, we put in maybe new stents if needed, cross with balloons again. So there is some technical issues with the equipment we use that may have an impact on the procedure. Also, a very important thing is actually how big a hole can we make in the side of the stent when we like to access a significant side branch that we don't want to lose. So, just to conclude and start the session, bifurcation main branch is often tapered. So it's nice to have a stent which is capable of making a big hole in the side. Also, to have the capacity of being conical. And also the bifurcation PCI needs appropriate cell diameter, again, to make a hole for the side branch. So let's open the first session and hear some informative talks from the Synergy universe, and hopefully we will not find a heel of Achilles. And with having said that, I would like to introduce the first speaker, Professor Robert Jan van Goyns. Please, Robert.
Thank you, Jens. It's a beautiful introduction. Let me see my slides because they go on exactly where I think you were ending on how are we going to achieve left main, which is, I think, sometimes the most difficult bifurcation to talk about. And I'm going to combine something of my results we just discussed earlier and then go limbs on the ideal left main trial. So the requirements for left main stent, going to mix with them with the requirements for bifurcation stent. But even the left main stents, I think they have the special subset of procedures. Talk about the large diameters, and especially the large overexpansion capabilities are necessary. If your proximal LAD is 3.5, you might want to go up to 4, 5, or even higher in the left main area. That's more than in an LAD diagonal bifurcation. Ostial stenting, usually a standard practice of our left main treatment, and it was already known for many years that this area has, of course, different patterns in your wall construction, and that's why you need the highest radial strength you can achieve in this area. A lot of the left main includes bifurcation treatments. 63% of the left main in original Syntax trial had bifurcation treatment, and bifurcation treatment is either one stent or two stents, which was 39% of the left main in Synergies, but also one stent, but usually then overlapping distally in extended disease, depending on how high your Syntax score is. And I think there is a reasonable to think about thin struts, which have the fastest and best coverage in a rapid moment. Also, this time to coverage is important because in general our left main PCI patients are significantly older than non-surgical patients. If you compare the PCI registry in Syntax, that was 71 years old versus 65 years old in a randomized study group. And the higher bleeding risk is especially for these elderly patients, and they prefer a shorter duration of the APT. Thinking about the diameter of the stent, I always use this from James Shand from Belfast and Simon Walls, who they looked at up, and they can see that their average cross-sectional area was 20 or close to 25 square millimeters, somewhere between 5 and 5.6 millimeters. In diameter, so these are significantly higher than our largest stent we have at the moment. If you can see the maximum diameter somewhere in the stent, that's even not mainly at the area of the stenosis, but if you want to have full apposition, to the right you can see that on the column you might have 5.6, 5.5 mean or average for the series of stents, and sometimes up to 6.7 or 6.4 millimeter in diameter in certain areas. We checked that in Rotterdam. I didn't believe these data for the first moment. We looked at all our IVUS data, 865 patients who had an IVUS pullback from the LAD in the left main, and then we especially looked for the non-diseased left mains, because you want to reach up to the healthy part, where you have minimal amount of disease. So this is the definition we used, and that came up for 152 patients. And then we also tried to do a body correlation to the body area. So our average vessel diameter in this segment, in the non-diseased left mains, was 5.6 millimeter. And only 13% of the patients had a left main smaller than 5 millimeter. The correlation was body surface area. You can see that's pretty much a cloud of dots. So you might not always predict just from the size of the patient how the area should be in the left main. So this is some of the data we know about stents and large diameters. This is the first table, which is the official table, and you can see what are the labeled diameters which you have allowed. You can see that our friends for this sponsoring session, Synergy and Promise Premier, have the largest labeled. We just started this session with 5.75 as official labeled diameter. But that even gives room for more post-dilatation if you want to. That was already studied by Nicolas Farr in this nice table that even if there's no label for science, you can see that even the science can reach 5.5 when he was using 6 millimeters post-dilatation balloons. So we did do some additional bench testing in this post-dilatation session, either for the POT or for the final kissing balloon dilatation. But this time, compared to the other studies, we wanted to use different sizes of balloons for the final kissing balloon and different pressures for the POT and the final kissing balloon. And then also measure the recoil and the radial strength of this newest generation thin strut stent. And our target was to reach 6 millimeter in diameter. These were the combinations we had. That's a POT with a semi-compliant balloon, the Maverick at low pressure, 6 atmospheres. The next step was a series of stents with 14 atmospheres. And then we switched for a series with the NC balloons, the Emerge, for 24 atmospheres. You can see for the final kissing, we had 3 options. Undersized is what was relatively interesting, because for a 6 millimeter target vessel, you could maybe think 4.0, 3.5 is pretty large in the left main, but that is by finesse law still undersized. So we used the officially sized balloons, which are 4.0 and 5.0 combination to follow the correct laws, either at 4 or 12 millimeters. So that's optimal sized, low pressure or standard pressure. These are some of the examples. You can see that was all done in silicone tubes. It was all done in a water bath of 37 degrees, and the tubes are 6 millimeter. It was a calibrated scope used to measure the maximum and the minimum diameters and the null post area. These are some of the results. These are the 3 final kissing combinations, where you have the standard sized, the 3.5 and a 4.0 combination. You can see that the diameter in one direction, outer diameter, was indeed 6 millimeter, our target area. For the larger combination with the low pressure, 4 atmospheres, optimal size, that didn't reach 6 because they are pretty much flattened. They don't sum up in diameters yet. Only if you go to 12 atmospheres, you can get over 6 millimeter in diameter. Now, diameter is of course not what you really do on these vessels, on these stents. So also we have this table, the graph on the areas, and you can see that even this final kissing with the small balloons, undersized balloons, that did reach 6 millimeter, but it definitely didn't reach anything in the area. So anything between the 20 and the 30 millimeter of area, that's 8 square millimeters of metal post area. Only in the final kissing balloon with optimal size balloons and a high pressure of 12 atmospheres were close to the target area we needed. This is ellipticity for the stents, all above 1 in the combination of final kissing balloons. So the conclusion was that adequate sizes are necessary. In principle, you really need a 4.050 to get the correct area. The pressures are necessary to get sufficiently high pressures, but still you might end up in serious ellipticity. So what did we learn from the settings where we used the POT balloon, the semi-compliant balloon versus the non-compliant balloon with these 3 different pressures? I wanted to realize and match these pressures to the post-dilatation balloons used. So we had this Maverick balloon, 6.0 in diameter, which normally says 6 atmospheres, 6 millimeter in diameter, and could reach 6.4, and the Emerge at 6 atmospheres should be 6.1, at rate burst pressure close to 6.3. That's what we are not going to achieve if we are doing that inside a 4 millimeter stent. And that's what I'm trying to show in this graph. You can see that if you do the 6 millimeter balloon in the 4 millimeter stent, you only reach 5.2 millimeters versus the 6.0 millimeter, what is the compliance chart of the balloon only. The rate pressure balloon, the POT semi-compliant rate pressure, did reach 6 millimeters, still not a 6.4 which we read from the chart. This is due to the metal which is constraining this balloon. Only with the NC and the high pressures we did get something which was close to what we thought we were going to get. The areas are much more closer to the targets we had. Ellipticity was 1. So now we could add to this graph from the graph from 2 years ago, now the synergy to know what we have to do. So this one was now theoretically labeled 4.0 to 5.75. And if you want to go to 6 or 6.2 is available with this combination of balloons. So coming back to the title, the requirements for the left main stenting, large diameter. I think that we now have data up to 6.2. We know the radial strength is very high for this stent. Earlier we discussed that the radial strength is maintained at these high diameters. Summary, I'm going to skip that for the time. The POT, what we said, doesn't follow normal compliance charts. High pressures are needed. For the last minutes is to introduce and update you on the ideal left main, which is then improved drug-eluting stents in an all-comers left main trial. And you have to see work close to that with Keith Oldroyd from Glasgow. And then we have these countries, France, Poland, Germany, Russia. And these people, if they are around, thank you. And if they're not around, thank you for contributing, because the study is running faster and faster. It has two objectives. So it's an objective where we have a short-term angiography and a long-term clinical outcome after implantation of this newer generation stents with a shorter dually plated therapy. We selected 4 months as a DAPT therapy versus the 12 months on the stent with the permanent polymer and a little bit thicker strut in an all-comer setting of unprotected left main. Multi-center prospect randomized trials with follow-up up to 5 years, and we will have a subgroup of 100 OCTs at 3 months from the first enrolled patients. That's what we have in there. This is an example. I used this one not from our patient group. If we can start the video. This was first of the study done by Dr. De La Torre. This is an example of the synergy with this abluminal coating. And you can see this already only 2 months and see how fast it is covered. And I think we can hope to show that we can do this safely, that in a left main with a short DAPT therapy. The update, our target is going to be 818 patients. And we started in the end of last year, and we have just reached today 167 patients with 20 sites or 17 sites open, and mainly since the last sites opened in the summer period, we are now getting above 1 patient a day. So we hope to complete that in 1 year, maybe earlier next year. That should be it, I think. Thank you for your attention.
Thank you very much, Robert. Just one short question about the duration of inflation. Did you test different duration, or did you test several inflation in the same vessel? Because we learned from Japanese people that there is a big difference. So what was the protocol for?
No, the protocol was it was going to be in the 37 degrees. So, and we kept the balloon inflated for 30 seconds. It was one time, 30 seconds. That was in all IFUs, also for the metallic stents, give 30 seconds. We did even at the 4 millimeter, didn't see any recalls is 2.5%. Or lower, the higher you are, but you have to keep it for several times to avoid acute recall.
Okay, I think it's a very important point. Of course, 30 seconds in the left main is a little bit long. So what is your recommendation? 2 times 15 or?
That's what our clinical practice is. We just follow the blood pressure and see at the patient how the patient is tolerating. It's dependent if it's a very large right coronary artery, you know all the tricks. But just like absorption, sometimes we deflate and we do a second inflation just to keep our time there.
Do we have question in the audience or comments? Okay, if not, we can. Thank you very much. So we move to a practical presentation about the CELTIC bifurcation trial by Dr. Spence. Optimal bifurcation technique in Medina 111. With a question mark.
Thank you very much for the invitation. Professor David Foley, the principal investigator for this study, actually had hoped to be here, but for family reasons couldn't, so he asked me to step in. We're participants in the trial. So this is really looking at the CELTIC bifurcation study, which is currently recruiting, using the Synergy stent versus the Zion stent in 111 Medina classification, bifurcation lesions, non-left mainstem, using a Culotte technique. Now this started recruiting just at the very end of last year and is planned to be finished by hopefully middle of next year. And the plan's 170 patients, non-inferiority and primary endpoints at 9 months, looking at a composite of myocardial infarction, stent vessel failure, and stent thrombosis with angio follow-up. So David Foley and Simon Walsh, my colleague, are the principal investigators. It's being indirectly sponsored by Boston, but run through the CERC organisation, who are also providing core lab analysis. These are the participating sites, so Irish sites, Scottish sites, and English sites, but we've kept the Celtic name. And the hypothesis, when first proposed really back a couple of years ago, was the concept that the modern generation drug-eluting stents should facilitate good clinical outcomes in Plan 2 stent bifurcation treatments. The anticipated outcomes were that bifurcation Culotte stenting would demonstrate better outcomes than those published in the randomized controlled trials, and the hope was that by examining 2 of the up-to-date platforms, this could be demonstrated. The primary outcome measures were composite, angio control at 9 months, and the clinical parameters mentioned before. This, of course, was before this was conceived and designed whilst the EBC 2 study was enrolling. So, of course, we now have the preliminary results at EuroPCR of EBC. So I suppose just to try and put this in some sort of context. So this was the starting point really when we were thinking about this trial. Of course, we all know this meta-analysis suggesting that a simple strategy certainly has advantages or no disadvantages relative to a bifurcation dedicated approach in bifurcation lesions. If we look at this, of course, we're aware that a big driver for a lot of the for the matching or the worst outcomes in the complex group is the peri-procedural myocardial infarction. You also see a signal for stent thrombosis, not statistically significant, but numerically a little more in the complex group. And of course, this is then reflected in the consensus document that we've all got copies of today and was published earlier in the year, namely to state that the simple approach seems to be best. However, the consensus did state that in cases of bifurcation with large side branches with osteal disease extending more than 5 millimeters, a 2-stent strategy could be utilised. However, of course, this has been addressed by the EBC 2 trial. You can see the hypothesis there, trying to address this group particularly. And the preliminary result, which David Hildick-Smith, who may even be here, presented, indicated really this was a well-conducted trial, high completion of final KISS. The trial seemed to recruit truly large side branches, 2.72 side branch diameter. And of course, simple strategy didn't really seem to be any worse. In actual fact, there was no statistical difference in these 2 trials. Now, again, the driver for a lot of this was the most of the events were in the early 48 hours, peri-procedural MI. So if you look at the Celtic bifurcation in the context of this then, so we've got the Nordic pool data, 17.3% for the complex strategy versus 10.1 for MACE and TVR at 9 months. EBC 2, clinical endpoints, no angiographic mandated follow-up, but at 12 months, 10% versus 8%. So certainly a improvement for the complex strategy, but certainly not beating the simple strategy. However, the peri-procedural MI, as we've mentioned, was a big factor for the two-stent strategy. So I suppose the question is there still a role for further improvement? And we certainly can see that it potentially improved technique, better application of final kiss, better sizing. In other words, technique improvements may have accounted for some of the fall from 17 down to 8%, or we could hypothesize so. The other question is, could we see a further stepwise improvement with a better stent platform, stent drug, and indeed polymer? So we feel that there still is a potential hypothesis-generating element to the study. And indeed, if we look at, this is the Premier platform, which has a similar connector profile to Synergy, two connectors in the main body of the stent, versus a 3-connector study. So you can certainly visualize how potentially the side branch may be more easy to access and maybe have better flow dynamics potentially. So again, supporting at least exploring this hypothesis. I think those should move, but aren't. But in any case, just visually reinforcing that. So again, you've heard a fair bit about the Synergy stent there, and I think it's true to say that the Biomatrix or the Nabori stent was what was used in EBC 2. So there is certainly the Xience Expedition and the Synergy, which are being used in the CELTIC bifurcation, have a stepwise improvement in terms of stent strut thickness, and Synergy is the bioabsorbable polymer. And therefore, I think it's fair to say that we could argue that we've got more advanced stents being used within this study. So the studies are 170 patients, 85 in each limb, 1-to-1 randomization, true 1-1-1. As I said, we potentially, I suppose, if the event rate is substantially lower, and we don't know, of course, but if it is substantially lower in the complex groups in this study, potentially, I suppose, it could open up, again, the possibility of a definitive conservative versus Culotte study properly powered for clinical endpoints, potentially. So the inclusion criteria, just to go back to the CELTIC study, the usual patients, there's ST elevation myocardial infarction is an exclusion, true large side branches, true 1-1-1 Medina classification. These are the exclusions, the typical exclusion criteria. And then the follow-up, so a little bit different than EBC 2. I mean, it's powered for non-inferiority, and there's an angiographic endpoint. The study duration for the enrollment duration hopefully will be 12 months. Patients will be followed out to 24 months. And then just talking about the Culottes, so trying to maintain high standards, mandating POT both after the first stent is deployed and at the end, and then mandating kissing inflations with sequential high pressure, and then a final nominal kiss. We have encouraged, but left it as discretionary, the final post-still, and adjunctive imaging is encouraged. So hopefully what can be a high standard study. So the 9-month composite endpoint, so we've included binary angiographic stenosis. This will be core lab adjudicated and added in stent thromboses. So meaningful endpoints. Then secondary endpoints, some pieces regarding technical aspects of the study, whether our radiation dose, procedure duration, contrast dose, of course, additional maneuvers, the sort of maneuvers increasingly we have to use to ensure we execute the final kiss and so on, the use of extra support wires, anchors, mother-daughter catheters. We're going to specifically look for longitudinal stent compression and at the index implantation, and at the angiographic follow-up, again, specifically look for stent fractures. Clinical endpoints at 24 months then, as listed, so the usual, and including definite and probable stent thrombosis because of the signal in the complex groups that this may be a disadvantage. And we've started enrolling, and that's the cadence, and that's the numbers so far. So just 35 cases so far of the planned 170. So thank you.
Thank you very much. I think it's a very interesting study. One question about the primary endpoint at 9 months. Is it clinical endpoints before the angiogram? Because we know that the angiogram influences the clinical outcome. So do you have an endpoint, clinical endpoint before the angiogram?
Yeah,
and then you have the angiogram, of course.
Yeah, the patients will be contacted for a clinic assessment with the research nurse and physician, and then be slotted on for cath after that.
So before. Yeah. I think it's a very, very important because it may influence the TVR at follow-up. Any question in the room about this? Yes?
Yeah.
There is some kind of angle that is exclude or include this kind of...
No, we've tried to keep it...
How many patients did you screen it to have this small number of patients included? Because, you know, in an ideal set, Culotte technique we know is a perfect technique, but there are not so many people that we can treat in this way. And if you compare this kind of technique with another technique, this is the major problem probably.
Yeah, I mean, it's always challenging to get patients into these sorts of studies. It is a it's true 1-1-1. So first of all, you're already it's narrowing it right down. It's not no STEMI patients, no CTOs, and no left main. So that already takes out quite a lot of patients. No, we're not worrying about angle. It's really very much at the operator discretion. The slow recruitment has really been just the centres are only really coming on stream. So we do anticipate it ramping up quite rapidly. But yes, I mean, we were involved in EBC TWO. It was quite a struggle, despite looking quite hard. Whenever you go down through the inclusion-exclusion criteria, it is actually, you think in practice, often there's more of these patients around, but once you go through the inclusion-exclusion criteria, some patients refuse, and so on. That's the way it is.
Very short question. The biomarkers, periprocedural myocardial infarction is part of the endpoint.
Yeah.
Yeah, which means that will increase the result and maybe make it possible to see a difference between the two stent platforms and stents in the same.
I mean, I think that's the hypothesis. Hopefully, maybe these advances in stent strut thickness and conformability, and maybe the difference in the connector may give a signal. Just hypothesis generating.
Yeah, excellent.
Do you have a recommendation for the duration of double antiplatelet
12 months
treatment?
mandated for dual antiplatelet.
How much?
12 months.
12 months.
Yeah.
Okay.
Very good. Thank you very much.
Thank you.
And now we would like to welcome the next speaker, which will be Andres Erglis out of Riga, and he will talk about stent and scaffolds, a synergy of technologies in complex PCI. Andres?
Good afternoon or good evening, and thank you, Jens, thank you, Thierry. And I'll show a bit our experience, what we do in Riga now, and it's quite interesting that it's the name of presentation, Synergy of Technologies, and also we use a Synergy stent, but not only, and also a scaffold. This is my disclosure slide. And of course, it's always a question about left main, how we can treat and how we should treat, and also why we treat in one or in other way. And of course, we also know very well that the main problem with stenting, and if you use especially two stents, then it is a restenosis on circ, an ostium of circ. If you use one stent, there is no big problem, and that's, of course, we recommend it to use one stent if possible, but of course not always is possible. And it's not only from this study, we know from so old days, and I remember on Patrick's data, and so many data, it's coming from 90s even, and it's always was a problem with circ. Of course, it also was with bare metal stents. And there's no question that we should use drug-eluting stents if we go for two-stent strategy, and especially in left main. And then we started actually a couple of years ago, or maybe now it's a bit more, because now we have also a 2-year follow-up. We started try to exchange this one drug eluting stent which goes to circ, ostium of circ, with scaffold. And as you know, we always, we do more than 15-year registry for left main intervention in our institution, and we always use very aggressively pretreatment and plaque modification with cutting balloon. It's always was I was guided. And in this study, and then in previous years, then we tried to cut or to modify plaque in ostium, and then to put only one stent. And if there are no flow limitations, and as we know, if you do with right appropriate size, I was guided cutting along interventions, and you can make only very controlled dissections. And then we leave this for like with some GPs and GP2BCA blockers, and actually with good results. But now we try to do a bit a new method and to combine BVS and this for left main intervention. And I don't know why it's not. This flow chart. You see this, of course, this patient angio and clinical suitable for left main bifurcation for angio or CT, IVUS, and IMAP and FFR, because we also put the study and especially with computational FFR in the idea that in future, if you use BVS, you can also use for patient follow-up computational fractional flow reserve. And this is quite interesting, and we are working with heart flow for long, and this is, I guess, will be really interesting to see how it works. And then post-procedural, as you see, this is also angio and OCT and IVUS and FFR, and actually now we did for 12 and 24 months, and then we will see, looks like that it will be really interesting as in Patrick's study with BVS, also 5-year data, but so far I will report you 1-year data. This is now we have more than 45 patients, and we actually, the goal is at least 50. This is now nothing very, very special. As you see, that is preserved more or less left ventricle ejection fraction, and if you look on mean syntax score, this is 27, 28, but with syntax score, it's always a question how you count it, and we try to do this very properly, but of course this is sometimes in a different way. As you see here, radial approach is 35%, and cutting balloon actually for both vessels is more than 90%. And this is also quite interesting. When we analyze the data, this 8% are really important. If you look on circ, there's a 95% of cutting balloon, and if you look on stenting technique, there's a T-Stent technique or mini crash technique. Of course, I don't think so that it is a real definitions of, because this is a question how we can call this, and you should remember that it is of course not like regular 2-stent technique, because this is a Synergy+BVS. This is if you look on 1-year follow-up, there is a 25 patient. This is 100% follow-up. Death rate 0, cardiac death 0, QMI 0, TVR 4%, TLR 3%, and then you remember that we also not use for 100% a cutting balloon. But if you look on Synergy group, there was no any MACEs. And this is one of examples that I wanted to show. Hopefully it will be. Of course, this is a very low syntax score. That's why I'm always saying that maybe it is, even if you have a really difficult left main, the syntax score could be very, very low. But you see the isolated stenosis, and that's of course like how we started our procedures years ago. Because of patients like this particular female, 76 years old. Maybe it is, I don't know why it's not going. Could you help me with next slide? Because it's not. Okay, there's right. It's also it's no problem. Maybe next one. I don't know. It's not working. Next slide, please. And this is FFR, as you see, is really significant lesions, and for LID and LCX, so 5.3 and 4.6, next one. And of course, the question before making a decision how to treat, how large is the side branch, diameter, vessel length, and myocardial territory supplied, if the side branch ostium diseased, if yes, that is the severity and length of the lesion, is the severe disease in the side branch beyond the ostium, what is the angle? Of course, it's maybe not for this particular patient, but it's if you look on all of our patients, then we always need to, like in checklist, to answer all these questions, and then we can also to go for best possible treatment. This is what we discussed today, and I will not go to again back and how to do this, or in one or two stents. And for this particular study, of course, it was, as I said, only patients where we plan to use this strategy. This is pre-intervention LID. I like very much those pictures because you see very well how it looks like intravascular ultrasound, how it looks like the lesion, how it looks like actually this inside bifurcation, the substrate of lesion. And what I always try to show, where is this? What I always try to show my students, as you see here, for example, it's really calcified left main. But and if you see it here, but on the other hand, this is a quite tiny. It's like usually in tube. And that's why the cutting balloon is working so well and so good in left main if you use appropriate size. If you use OCT in this case, you can't see a real dimensions of vessel because of penetration. And this is why I said that those are two complementary methods, but I'm not sure that we can do OCT guided interventions for so big vessels, because then if you use this, then you should go for really appropriate size of devices. This is pre-intervention, and as you see how is this stone make to sand, and now this is pre-intervention now, and then it's as you see here, it's done two interventions with 3.25 cutting balloon and 3.25 in both in LID and LCX. And I want to say that I'm getting unfortunately or fortunately older, and I'm using smaller devices. Actually, of course, it is a left main for 4.0 at least cutting balloon. And if you do this gentle, then it is, and this is, if you do in appropriate size, you can do gentle with low atmospheres, and you can get a really good result. Okay, this is it's done after cutting balloon, and then we did T-Stenting in this particular case with absorb. We try to put, this is a like balloon here, and then we're coming back with scaffold and try to land this, as you know, the scaffold have a marker, and how to try to land this marker inside the left main. And then it's of course then we crush bit, like, or it is a T, or no, that doesn't matter how it's called, but actually it's how we do that. And then we put Synergy stent, as you see here, from left main to LID, then rewiring again back to circ, and of course finalizing with two non-compliant balloon, with kissing balloon technique, and final usually we use pot for this left main, because this is not 3.5 or 4, but usually it's 4.5 or something like that. And afterwards, it's as you see here, the FFR is done 0.87, 0.89, and that's what we did in both vessels. And of course, before that was done also CT scan, because as I said, we do this. Of course, in lack of the time, I will go quickly for next pictures, but as you see, actually, I like very much this, really, I like very much this picture. I'm not sure that there should be 8 square millimeters, because usually left main is much bigger. As you see, at least here it's 10, here is 7, and that means that it's fit for all this measurements. This how looks like bifurcation in an OCT, and OCT is really good after this, and this is follow-up. This follow-up in 1 year. Actually, the lady has follow-up also in 2 years, but if you look here, the carina and everything is looking very well, and in future there will be nothing. That means that practically we become from 2-stent or synergy technology to 1-stent technique, because this BVS will disappear in next 2 years. Again, this is a follow-up measurements, as you see, 0.7, 0.9, and this is follow-up OCT, as you see here, how it looks like, and the centralization. And yeah, that's it. Thank you very much.
Thank you very much, Andrej. Any comments? Yes?
Just one short question, maybe I misunderstood. If you are intentionally doing mini crash with fixed struts inside the left main, so after those 2 years that you are mentioning, you will have gross mal-expansion of the stent and malposition in the distal left main.
Again, this is so many years I'm hearing the same question. Actually, if you look on, doesn't matter, every follow-up for left main, you never have a really stent, because what we heard from previous speaker, we usually use 2 small devices. You always have some, even not malposition, but you always have some under expansion. You always there have some space. What we see in here is that practically there is no, I don't know, is there, I really think that it's very, very interesting point, and we will concentrate to understand what's happening even there. But what we see, practically nothing. I don't know exactly what is there. I'm even not sure that with nowadays technologies, and then maybe Patrick can comment this, but with nowadays, I mean what we use here, IVUS or OCT, we can even say what is there. Is this substrate, is this the scaffold material, or something like something different, or how it will transfer? But actually we analyze this segment, and there is no any problems, not looking at problems. But the question again is, of course, this is what we discussed in inside in lab. What we really do, is it mini crash or T-stent, which is also like with bit like, some mini crash?
No, I'm just saying, if you have 0.3 millimeters at least malapose stent in the left main, I'm worried. I don't know. It's just concern. And if you don't see it in the couple of 100 patients, doesn't mean that it's not dangerous.
Life is dangerous, of course, yes.
Andrej, just one technical question. Today, many people are recommending to use a decay crush.
Excuse me? Decay.
Yeah. Many people are recommending to use a decay crush rather than a classical crush, and we know that in the bench it's better. So what is your strategy today? Is it still a crush rather a decay crush, or what do you do?
Thierry, we have only 50 patients. I don't know exactly. That's what I showed, and maybe it will, to create a new ideas, how to do and what to do. But this is how we did. Then again, I'm not sure that if we look on 50 patients, because we have different techniques. We have, for example, some two Culottes techniques, only because we can't go through the struts, because the first strategy was to put first from left main to LAD, and then to go through the struts with BVS. Then once we can't, in one case we can't go even really deep with, I mean, deep enough with scaffold, then we put like in Culotte technique, and then to continue with other one. And this is, of course, we need more information to understand which is the best one. I can't and the diluting stent.
Yeah, but in the example that you showed, there was no significant disease at the ostium of the LED. So why not doing a left main circ and provisional for the LED? Okay, bad question.
Different study. Yeah.
Okay.
Just a short question, Andres. In a preliminary series, you presented 25 patients, 1 year follow-up. There was a 16% TVR, which is a little bit high. 16% for patients. Was it symptom-driven or just after angiography?
Right. It's just after angiography, and then it's also quite interesting that, of course, usually we have, this is, how to say, sometimes we leave some lesions. And it's not high. It's 4 out of 25. It is actually TVR. It's not so. It's not. But it's not TLR. But about TLR, you should understand that we also have some learning curve. And for example, we seen couple technical aspects what we need to improve, and even it is maybe more for future when also BVS will be better or not only better, but more easy to use. And this is, of course, it's the case. It's, you know, this is only first 25.
Last comment from Dr. Shen, the specialist of decay crush.
No. Actually, I have no remark about decay crush.
Inventor of decay crush.
My concern is the stent fracture after kissing balloon inflation or part technique for your study.
Sorry?
Yes, stent fracture.
Stent fracture. Yeah, this is again. This is what we need to go for more careful analysis. We seen in couple cases some crash of stent, but only in one. Even I don't think so that in this series we seen some clinical consequences. But I agree with Goran what he says, that we need more data. Of course, we need. It is no question about 50 cases, but we always start with something.
Corrado?
Last short question. Why did you choose to put a BVS in the circumflex, which is the site of restenosis, and the BVS has a low radial force as compared with the metal stent?
Yeah, but again, what I want to say is that what we do, if you know what we did in past, we always did plaque modification with cutting balloon, and then we always were a bit afraid to leave this because there was some not covered, or controlled but not covered dissections, and now idea was to go for really aggressive pretreatment and cover this with BVS, which will disappear. And now again, this is a first generation BVS, but maybe will be BVS which will disappear in 30 days, in 60 days. And it's only for acute phase, because everything is done by scoring balloons. This is the idea.
Okay, thank you very much, Andrzej. So it's time to make a short conclusion. I think we have every year better stents, better profile, better deliverability. But the technical approach in left main is still in debate. We are going more and more provisional, but I see that many centers are still doing a lot of two-stent techniques in the left main. So this is something that we should discuss, and maybe we'll have a better consensus this year about that.
We'll try.
Thank you very much. So we move to the next session. Who's going to